I would invite for the next case Dr. Enrico Bollito from the Institute San Luigi of Bassano, Torino. Please, Enrico.
Okay. Thank you, Professor. Oops. Thank you, Professor Fada. Thank you, Gazzano, for this invite. I starting apologizing for my English. It's not so good. However, my presentation will be not a real case. It is a challenge of what may happen in the real life if your job include urinary cytology. And the second challenge is to start this. Okay, easy. So, the first thing to be noted is that there is not a clinical information, but the average of information we have when we are examining urinary cytology is the age of the patient. We know any other information. In Italy, you don't know, recently we have a curious information. A test required by urologist is due to new rule in the sanitary system, but the information is required by urologist. Why does the urologist require this test? I don't know. So, we can start. Some very dark nuclei enlarged and with a nuclear cytoplasmic ratio very high. What's your opinion? Of course, this patient have also had hematuria, was a worker in the painter plant, but all this information I received later, sometime later this case. So, what's your opinion, audience? No, not the professor, I think, but also, finally, the opinion of the professor, but the audience, please. Number of that's all. That's all. No. Clear? Now, the young people, the audience. Suspicious. Suspicious, okay, yes. First question. Usually, urinary cytology is done on 3 samples. All showed 5 to 7, 1, 10 cell. I consider suspicious, or I consider whole group of sample, and I done the diagnosis positive for A grade. Your opinion?
It's difficult to make a diagnosis on one cell, even if how many?
In on one is suspicious. 5 cell, I think. Do you think? Do you agree? So three samples similar.
So my first impression is that the technique is not optimal. This is one thing. Oh, thank you. Okay, so I would say that the first image that you have here is a cell in a cell, or a cell in a cell in a cell, with one big nuclei, which is very big because you can compare it with the leukocytes. So we know that leukocytes, it's around 10 microns, and so you see that the big nuclei, indented and very dark, is very large. So, of course, this is something which is worrying the cytopathologists, but the color of there is a lot of hyperchromasia. And this hyperchromasia is so high that you cannot distinguish between degenerated cells and cells. So it could be something like what we call ink nuclei in urine cytology. Okay, so this is one thing. And so I think that on the left part, it's not possible to make a definitive diagnosis because you have always these degenerated cells that you have in mind. The one in the middle, or the picture in the middle, you have two cells. One is the upper one, which is a kind of apoptotic cells or necrosis of the nuclei, so you cannot say anything. But of course, the fact that there is some kind of apoptosis or necrosis is not good in urine, but this is also a 70-age-old guy. And the one which is extremely worrisome in this one, and why is because it's big as compared with red blood cell, and you see the nuclei, which is here, with a very small ring of cytoplasm, means that the nuclear to cytoplasmic ratio is probably more than 0.7. It's probably 0.8, something like that. But you have one cell. And then,
can I ask?
Just let me finish. Sorry. And then you have this one, which is difficult, probably the same than this one, but it's a little bit out of focus, and this one is again something which is probably a nuclei which is undergoing necrotic pathway. So you have two cells which are suggestive of a high grade, but so I wouldn't say high grade because two is not enough. So I would say
cell in cell or cannibalism are enough to
no,
do?
No.
Okay.
It is not specific enough.
Okay. However, my opinion in 2016 was positive for high grade, and a patient received a transuretral resection with an high grade carcinoma and a T1 lamina propria invasive with some nested features. In the last time, urologist performed therapy with BCZ and ultrasound, cystoscopy in the follow-up. But it was one of the cytology during the follow-up. Your opinion? The audience, not only the professor, because we want to play a game with you. Nobody? Positive, negative, undeterminate? So, the challenge is this, clear. This, in my opinion, is very easy. That, no. Fatta, dai. Non ce ne speravo che qualcuno di audience si lanciasse, non si lancia nessuno. Dai, facciamolo noi. Dai. Tanto li sbagliamo tutti, quindi non c'è problema. Adesso. Ok, allora dico io. My opinion was reactive changes, of course, in this case, but also in this. Do you agree? No. Suspicious? Or I will see. Okay. This was.
Can I comment?
Allora, but please.
No, so for this picture, in my experience, if I see this cell with very hyperchromatic nucleus, but the nucleus cytoplasmic ratio is
Okay.
not, okay?
This was the
Yes, this is
the
this is
discussion
the problem,
about.
because the criteria of
Because
funziona, se funziona parlo. No, parlo.
here we have no problem because the nuclear cytoplasmic ratio.
One question is more important. The criteria is not separate criteria. Say it's a food field. If you have this nucleus, it's a hyperchromatic nucleus, but you don't have the increase in nuclear cytoplasmic ratio important, that's is doubt. Maybe this is an artifact. This is the genetic feature. Another point, because in the genetic feature, the nuclei become very, very small, hyperchromatic. So you have to have harmony of the criteria. If the first criteria is not present, it's very difficult that the other criteria is present without the first. So this is a doubt. So another thing is the cytoplasm, is the genetic feature. In BCG, it's very frequent to find this cell. This is very difficult cell. This is not. So the same in this cell. Look at this cell. Hyperchromatic nuclei, very small, some irregular nuclear membrane, but the cytoplasm is too big. So it's not possible that is a tumor. It's not possible that. It's not possible that. This is, I will say, or that is a degenerate feature of the BCG. For me, the positive is not possible to give a diagnosis of positive hypercarcinoma. And so it's very important because it's a refractory BCG. It's a message for urologists, very important. If you give high-grade urinary carcinoma for these patients, probably undergo cystectomy or another very, very severe injury. Okay.
Okay. Gazzano.
Another feature, just to ask to Professor Vielh. So this feature, in my opinion, is a mucus. It's possible.
So this is a kind of combination of what you have in cytoplasm or the other cells. These are degenerated features that you can see in the nuclei. And I agree with my colleague that all these cells are probably only degenerative. And because we know that he had a treatment, a local treatment, I would probably say that it is maybe a UC, but you don't have the first criteria, which is a major criteria of the nuclear to cytoplasmic ratio of 0.5. So none of them have more than a 0.5, at least the most worrisome. So, you know, there are some phagocyte elements, probably including red blood cells inside. And so I wouldn't think about a mucinous component, because then it is not very coherent with the rest. Why should we have a mucinous component here and not here? So, yeah, it may be a glandular metaplasia, but then it's just a metaplasia. It doesn't mean something bad for the patient. Yeah, so I would stay on the atypical urothelial cells.
This case in 2016 was reported without using Paris. So this one was reported as reactive change, And this one was reported abnormalities of unknown significance. Today, using Paris, probably we have to use reactive cells, okay, negative, and probably inflammatory cells.
Negative for high grade on the left, negative for high grade on
And
the right,
AUC today.
and maybe how you see.
How you see
right.
today, okay? Okay. The time changing from old system and the new system is not so easy. So the question of Dr. Gazzano about the mucus have a reason.
You have to point to there.
Adesso, okay. Okay. The patient remained NED for 3 years. We have a few information during the COVID period because the patient lost the control for more than 1 year. And then arrived to 2022 with hematuria and a new evidence of an irregular crescent in the trigonal wall. So, cytology was too different. Some cell similar to previous observed, and some very different. The opinion of the audience?
But this may happen in the trigonal region. I mean, the kind of
Near a meatus. Oh, so referred by urologist, of course, I don't know, but was referred near a meatus. Trigonal wall, trigonal area. Some ideas? Well, high-grade carcinoma. Are you all in agreement? And that are a bit different from that. So, of course, for practical reasons, it was reported as positive for high-grade carcinoma. But I have had no other comment about that because why this aspect? Histology 1 month later was too clear. It's become very easy. But at the moment of histology, why this aspect? Remembering signet ring cell? Maybe?
No, but I think that in the region of the dome and the region of the...
Yes, in the dome, yes, urachal tumor, of course.
You can have a mucinous
Absolutely.
metaplasia, which may, and this is why I think Gazzano is right, is that probably the cells that you mentioned was already one of his population. But I wouldn't say that it's malignant. Thank you. I would say that these are metaplastic cells.
Okay, yes, this is a possible. So, this was TUR, two different tumor components, one urothelial, infiltrating high grade, typical classic, and an area of signet ring cell component. The signet ring cell component in the classic urothelial cancer is very rare. Maybe arise in condition of glandular differentiation that is not rare. 6 to 10% of high-grade infiltrating carcinoma may have a glandular component, but real signaturing cell is very uncommon. We have some differential diagnosis, of course, lacking a typical urothelial component. You have to consider as the first metastasis. We have no way to exclude a metastasis if we have no classical urothelial component. And we have another finding possible. The discoesive tumor, like plasmacytoma-like, may have some cell similar to signaturing cell. That is not our case. The component, urothelial component, is typical, and the signaturing cell arising in area of glandular differentiation. It is important in the diagnosis of urothelial variant for two different reasons. The presence of signaturing cell are a poor prognostic sign, and we have some controversial about the therapy. Usually is considered poor prognosis and poor responsiveness to all therapy. But there are some cases in disagreement. Sometimes isolated author reported a good answer with gemcitabine and platinum or other, and also radiation. But thank you for your attention. I hope I have not bored you.